All right. Well, welcome everybody, and good afternoon. This is Bruce Robinson. I'm speaking on behalf of the DOPPS program at Arbor Research Collaborative for Health in Ann Arbor, Michigan, and we are here to present DOPPS Practice Monitor trends in U.S. dialysis practices, as well as the latest policy updates following the Advancing American Kidney Health Initiative. And I do appreciate folks joining us here this afternoon. All right, so after my brief introduction, Doug Fuller, biostatistician here with the DOPPS program, will provide an overview of some of the most important dialysis practice trends. I'll give some slides related to depression screening and dialysis, which is a recent QIP-related initiative. And we have the pleasure of welcoming Miriam Godwin as speaker from the National Kidney Foundation to provide us an update on Advancing American Kidney Health and related policy updates and additional policy updates relevant to all of us in dialysis practice. And for this hour, we intend to spend the first half hour going through Doug and my slides, and the second half on policy updates that Miriam will provide. As always, we're interested in feedback from folks, and actually we have some slides on that in just a moment. Before then, I'll just provide a slide here showing funding acknowledgments, and I'd like to give a warm thanks, as always, for our DOPPS program funders providing the support for independent scientific research to improve dialysis care. Okay, we have an active Twitter presence, and at any point, please follow us at DOPPS Study, and please feel free to tweet as well about today's presentation. Okay, so we welcome, as noted, I really would like this to be as interactive as possible. I certainly welcome questions throughout the session, and at appropriate times we'll pause to provide answers verbally. And if not, then we'll respond electronically to you as well. So please submit your questions using the chat with presenter feature, accessed by the blue icon located at the bottom left corner of your screen. As well, we have about 4 interactive polling questions today. We've done this on several occasions and found this sort of fun and help keeping the audience involved, and it's great to hear back from you. So we'll offer several poll questions about dialysis treatment practices, and please be assured that responses remain entirely confidential, and indeed will not be saved after we collect them. As well, by the way, the questions are really opinion-based, so there is no right or wrong answer. So please feel free to provide your opinion in response to those questions. When the poll is open, displays on your screen, please answer the question and hit the submit button. And next slide, please. All right, just a note as well, we do provide updates based on the DOPPS Practice Monitor. So the DOPPS Practice Monitor is our public website showing up-to-date trends in U.S. hemodialysis practice. We do update these data twice per year. The most recent update includes data through August of this year, so very, very current data. And with that, I'll pass the microphone to Doug Fuller to provide updates. Thank you, Doug.
Thank you, Bruce. So the first slide of my presentation is just looking at the front page of the DOPPS Practice Monitor. We have a collection of featured measures with some interpretive text to go along with that, key messages, as well as links to related slides that connect you to the Browse All Data tab, where you can find more than 1,900 figures and tables covering all aspects of hemodialysis practice. Our sample is based on a stratified national sample, randomized national sample of U.S. dialysis facilities. The current sample as of August of 2019 has about 180 facilities covering nearly 12,000 patients. These are coming primarily from the two largest dialysis organizations, as well as Visnex, which is a provider of EMR services software to primarily small chain, independent, and hospital-based facilities. The website, of course, is DOPPS.org/DPM. So the first thing I want to do is jump into a poll question about ultrafiltration rate. And previously we described that average UFR is lower than it was at the start of the decade, and we're curious to know what your all's opinion is the reason behind. Is this good for patients in terms of being reduced intake and more moderated intake of fluid, or is it potentially bad for patients in that they may be left heavier after treatment, raising likelihood of related complications, or perhaps you don't know? Please take a moment to respond to this first poll.
Okay, yeah, thanks, folks, for responding. We have roughly 2/3 of respondents said that this is good for patients, and then another 1/3 said that we don't know. A couple stragglers said it may be bad, actually, but predominant opinion was it's actually good. I would tend to favor this as well, although with some equivocation, because perhaps this is an area that hasn't fully been studied. Indeed, a number of publications, ours, but multiple other folks have noted that UF rates of above 13 are associated with worse outcomes, perhaps even a bit lower, less than 13 mils per minute per kilogram. But the practice across a dialysis center and across the population of reducing UFR, it's conceivable that that is occurring because we're leaving patients somewhat heavier, and as a result, of course, the thirst drive kicks in a bit less actively in the interdialytic period, and as a result, folks are gaining less weight, but at the same time being left a bit heavier. So I think it'll be important to understand with additional research in the near future as to whether over the last couple of years, as UFR has declined, whether indeed we actually see fewer hospitalizations, for example, related to volume overload. Anyways, I think more work to do on the topic. Anyway, and thanks, folks, for your responses. We'll move on to the next slide, please.
Yeah, thanks, Bruce.
Okay,
we'll jump quickly to look at average treatment time, average session length of a treatment. This is going all the way back to August of 2010 at the start of the DOPPS Practice Monitor. And so the mean treatment time has increased about 5 minutes over the last 10 years, from 217 minutes up to 222 minutes. Accordingly, the proportion of patients with a treatment time less than 3.5 hours has declined from 34 to 27%, which longer treatment time is thought to be associated with improved outcomes, so this would be a welcome development. Likewise, longer treatment time may permit lower UFRs, which were just discussed by Bruce. Next slide. And so this is looking at the trend in UFR, which we just discussed. 9.4 milligrams per kilogram per hour. And in August of 2010, this has declined pretty sharply down to about 7.8, but with relative stability over the last 3 years or so, about 7.8 milligrams per kilogram per hour. And as well, the proportion of patients with values above 13 has dropped by more than half, from 19% down to 9%. Next slide. So looking at ESA use, I'm sorry for the yellow text overwriting some of the numbers there, but we have been reporting the uptake of pegylated epoetin beta, which is a new product that was introduced several years ago, but just recently became available in 2018 to the small and independent DOs. And so use among those facilities has now increased to 28%, with a concordant decline in use of epoetin alpha or darbepoetin alpha. Use in the large and medium organizations is split nearly 50-50 between epoetin alpha and the pegylated epoetin beta, and darbepoetin use has all but vanished within that sample. Next slide. So the second poll question that we have for you is regarding the new HIF stabilizers. Phase 3 study clinical trial results were just released at ASN several weeks ago, and seemed encouraging. So our question for you is, do you anticipate that HIF stabilizers will substantially change management of anemia in your dialysis unit? And the responses are yes for most, yes mainly for incident patients needed dialysis, no, too early to tell, and if you don't know what HIF stabilizers are, you can select option 5.
Okay, yeah, I can speak to results then. So the predominant answer is that it is indeed too early to tell. I agree with Doug. There's been promising clinical development data, including late phase data with the roxadustat program, but it is indeed early, and we'll wait and see what happens. The drug has actually been approved in parts of Asia, both China and perhaps soon in Japan as well. So there'll be some opportunity for us to evaluate uptake and experience in other regions before final introduction to this market, probably anticipated in 2021. And indeed, a lot of promise, I believe, but also a lot of unknowns as well. I mean, the drugs would be essentially oral treatments for anemia with use in advanced non-dialysis CKD, potentially incident or even prevalent patients. And they do act by increasing endogenous erythropoietin release and as well by improving iron handling in the uremic environment as well. So, but anyway, it looks like about 75% of folks said that it is too early to tell. I had another, let's say 15% of folks who weren't aware of HIF stabilizers at all. Well, anyway, so much to look forward to in that realm and to see what happens and develops over the next 1 to 2 years. Okay, next slide, please.
Great, Bruce, thanks. Turning to mineral and bone disorder, this is a slide looking at the prevalence of various therapies for treating MBD. And so we see on the light blue line the proportion of phosphate binder patients using phosphate binders of any type is declining slightly starting in 2018. I want to note that between February and May of 2018 is when our facility samples switched from DOPPS 6 to DOPPS 7. So there may be some lower values or higher values, as the case may be, related to the switch in our facility sample. They don't necessarily represent an abrupt shift in trend. So the brown line or the orange line reflects the proportion of patients using active vitamin D. That is also largely stable. And the dark blue line is the proportion of patients using any calcimimetic product, and that includes both cinacalcet, the oral drug, and edocalcetide, which is the new intravenous. Interestingly, of the active vitamin D, about 40% of those patients are getting oral, with another 5% getting oral and IV-based drugs. Next slide. So, despite the fact that there isn't a substantial trend in treatment for MVD, we are starting to see somewhat of an increasing trend in the last 2 years with regard to serum phosphorus levels. The median value is shown in the blue line, and the 90th percentile value is shown in the orange line above. And so we have started to note that there is a slight uptick, particularly noticeable in the upper percentiles for serum phosphorus. A couple of things to note here. We do know that one of the large providers had recently undergone a recalibration of their central laboratory, and so we expect that some of the variation here, some of the trend here may be reflective of that as well. I talked about the transition from DOPPS 6 to DOPPS 7. There's also an ongoing study that is just getting started up called the HILO study, a clinical trial that will aim to examine the question of whether liberalizing or permitting higher phosphorus levels has any adverse outcomes for patients versus the more strictly controlled phosphorus levels that currently targets that currently exist. So we definitely look forward to that. I think recruitment for that study will end in 2023, so it will certainly be several years before we get it. Next slide. Looking at phosphate binder use by type, put this slide up here just to demonstrate primarily the continued increase, steady increase in the use of iron-based phosphate binders in the dark blue from 3% about 3.5 years ago to just over 12 and 13% in the most recent data we have. We've seen a corresponding decline in the proportion of patients prescribed sevelamer, which would be the combination of the yellow and the orange segments on the graph. Next slide. Parathyroid hormone, we've talked in past webinars about the increase in PTH. Interestingly, with the introduction of edocalcetide in 2017, actually, but more widespread use through 2018, we're actually potentially seeing a decline or a stabilization, at least in PTH levels, which we think is encouraging. DOPPS data has shown in the past PTH levels above 600 picograms per milliliter are associated with increased risk of clinical outcomes, and so we welcome this decline in PTH, but additional follow-up and analysis is needed to confirm this trend. Next slide. So again, talking about calcimimetic use, we do show overall calcimimetic use has been steady around 28 to 30%, but with the introduction of edocalcetide, we're showing that in the yellow bars here versus cinacalcet in the blue bars, and we can see that there's quite a discrepancy and difference in the use of edocalcetide between large and medium DO sample and our small DO and independent sample on the right, where about 20% of patients in small DO and independent facilities are using edocalcetide compared to about 4% of patients in our large DO. Next slide. And so that brings us to our last poll question for me. Average serum phosphorus levels are starting to rise among U.S. dialysis patients. In your opinion, what is the most important reason? Options are higher targets, lower effective dose of phosphate binders, perhaps related to the transition toward iron-based phosphate binders, lower use of calcium-containing binders, changes to diet, I don't know, or other.
Yeah, Doug, thank you so much. If folks have any other ideas, we'd be happy to have you send them to us electronically. I had been a bit surprised actually to see this trend. It seems like it's real, as Doug notes, given it's been now persistent over the course of several months. Our data, but also others over the years, have indicated very consistently associations of high phosphorus with worse outcomes. Though the causal link remains a bit uncertain, and as Doug noted, the high-low clinical trial is designed given the recognition of general equipoise with respect to what is the optimal serum phosphate level. Okay, so just looking at answers I see number one, in terms of answers, actually pretty wide distribution amongst folks. Changes to diet, and I'm not sure why per se there'd be wholesale distribution and change to diet, but perhaps so. Secondly, lower use of calcium binders, which could raise phosphorus for a number of different reasons. And then sort of a smattering of results related to the other options. So it sounds like there's also some uncertainty and perhaps debate in the community here with respect to what's driving this change. There was one comment that we don't have enough home dialysis, which is true that home dialysis is a good prescription to lower, and longer dialysis is a good prescription for lowering of serum phosphorus. Okay, good. Doug, thank you so much. If we move on, you have a summary slide, Doug, as well. Actually,
so
Doug,
just in some.
Yeah,
go ahead.
Say, Doug, in the interest of time, maybe I'll just run through the bullets quickly. And thank you again, Doug. So, recent uptake of pegylated EPO beta, particularly in the small dialysis organizations. Now, long-acting ESAs are about 55% of overall. Slightly higher treatment time, but still a lot shorter than most of the countries we follow worldwide. Ultrafiltration rate declined markedly some years ago. It seems to have stabilized. Rise in PTH over time appears to have stabilized a bit, with calcimimetic use around 30% overall. And as noted, perhaps the most interesting recent finding is that phosphorus levels appear to be rising. Okay, and we'll be certain to follow that with subsequent updates. If we move on to the next section, and I'll be able to get through this fairly quickly, in preparation for ASN, I reviewed the literature, and also we sort of refreshed some of the DOPPS data on depressive symptoms in the dialysis population. Next slide. And this was I was asked to do so in among other speakers with the recent introduction of the QIP related to clinical depression screening and follow-up implemented in the 2018 payment year. And as folks who work in dialysis units are aware, facilities are expected now to report whether they conduct screening. Multiple screening tools are possible. None is identified as requisite. This is a reporting measure, so what proportion of patients do you screen and follow up on? There is the potential down the road for a clinical measure, which introduces a requirement to screen folks. In no cases, I think, have people talked about measuring or penalizing facilities on their patients' mental health scores, but just rather on whether it is indeed screened for and acted on. But again, as noted, there has, to my understanding, no movement towards even that clinical measure yet, just simply a reporting measure. Next slide. Depression screening questionnaires, there are many of them out there. Typically, they'll capture benign symptoms of depression, and some score above a cut point is indicative of possible major depressive disorder or subthreshold depressive symptoms. Next. Thank you. Okay, the Beck Depression Inventory is one that's really well known. A downside to that is that it is copyrighted and has a fee for use. Indeed, its reliability, validity is not clearly greater than other instruments. So others, such as the CESD 20-item scale, is commonly used. We use a 10-point CESD, which I'll show data from in just a moment. The PHQ, Patient Health Questionnaire, PHQ-9, is also commonly used. Both of those last two, CSD, PHQ-9, are examples of open access tools available from the web. Next. Okay, CSD-10 we've actually used this in our DOPPS program now for over 20 years. So again, a 10 question inventory derived from the original 20 question inventory with 10, again, the 10 questions as noted here. And patients are asked to respond between 0 and 3, and a sum of those gives you a score amongst 10, actually between 0 and 3. So some maximum in one score is 30. Greater than or equal to 10 has been considered indicative of depressive, screen positive for depressive symptoms. Next slide. You. With this in mind, the cut point of 10 or higher, we're showing this across about 12 different countries, with the U.S. on the right, and the prevalence of screen positive for depressive symptoms in the U.S. Most recently is 33%. That's anything in the orange or light blue. It is a bit lower than other countries. I think the reason for that is that actually our return rates on our questionnaires are a bit lower in the U.S., so we may be sampling biasing towards a relatively healthier population in the U.S. But anyway, in the range, our data and others indicate screen positive for depression in the range of 30-35%, really quite high. Next slide. Just to note quickly, in peritoneal dialysis, depressive symptoms are less common than among folks on hemodialysis. Whether this is causal or reflecting confounding and patient selection is uncertain. Next slide. All right, so prevalence of depression among dialysis patients, probably in the range of 20 to 30%. It's overestimated a bit by screening questionnaires because of overlap between symptoms of uremia and depressive symptoms, but probably still 25 to 30%. Next. All right, we were curious to understand whether the screening questionnaire actually helps, and what we have done separately in this graphic shows is the prevalence of depression by chart diagnosis. So it's actually coded in problem list, history of depression, or prescription of medications used typically for depression. And we'll see when we look at this, the combinations in the range of about 30%, roughly 30% in the U.S. And as noted, this is actually pretty comparable to the 30% that screen positive as just discussed. However, next slide. I was interested in the agreement between screen positive and chart positive, and that agreement is actually very poor. In the U.S., the kappa is 0.16. Complete agreement, meaning complete agreement between the two would be a kappa of 1. 0.16 is very, very low. So what happens is, in essence, and just focus on the U.S. for now, among patients who screen positive with a CSD of 10 or higher, only 40% have a chart diagnosis. That suggests that there is value to screening, as the CMS is asking folks to do. In other words, because that screening does help identify folks with underdiagnosed, who have not clearly been diagnosed with depression. at least to the best we can tell. At the same time, among folks who see CSD less than 10, 25% have a chart diagnosis of depression. So loosely speaking, that suggests to me that the screening questionnaire isn't perfect, and there are going to be some false negatives with that as well. Next slide. So just to summarize that section, agreement is poor between the screening questionnaire and chart diagnosis. The messages here, in my view, are that screening is useful. In fact, at least 50% of people who screen positive have been undiagnosed. Also that screening false negatives can occur. Two other slides. One is that if you look on the left-hand side, the risk of all-cause mortality for CSD above 10, averaging those two bars is around 1.5. And that point estimate for mortality is really, really high. It's as high as we see with any of our other diagnoses, for example, heart failure, and worse for many common diagnoses. So patients with depression are really at high risk for adverse outcomes, mortality included. Next slide. Last slide here simply shows, as one might expect, the risk of polypharmacy and overpharmacy, particularly in such patients. So patients who have a chart diagnosis of depression, in this case, over 40% of them are prescribed either an opioid or benzodiazepine or both of those. And as folks on the line know, either of those are considered often quite dangerous for dialysis patients, and the combination together especially so. So these folks, again, are at high risk. And on to the polling question. All right, this is our last polling question on depression. In your opinion, screening patients for depression in your dialysis unit is definitely useful. We routinely treat or refer for treatment based on results. Generally useful, but we're not quite sure what to do with those findings. Really not useful and probably not worth the effort. And then not sure. I'll give folks just a minute or so, and then we'll move forward. Okay, in the interest of time, I'll move forward. You can continue to answer if you've not yet done so. But anyway, the preponderance of answers were, I say very high majority, were that it's either definitely or generally useful. And so that's good to hear. So I think sounds like folks have been happy with the CMS mandate to collect those data. Actually, among those people who, again, it was perhaps 90% positive, and about it split evenly among folks who think it's definitely useful versus generally useful, not quite sure yet what to do with it. Anyway, this is a topic of real interest, and we'll be sure to follow up along with others moving forward. With that in mind, I wanted to introduce Miriam Godwin. This is the last topic for discussion today. Miriam has perhaps 15 to 20 minutes worth of slides, and then we'll have time for interactive discussion thereafter. Miriam Godwin is a health policy analyst with the National Kidney Foundation, and Miriam, we really do appreciate your speaking here today. Thank you.
Of course, it's my pleasure, and thank you for having me. I will try to run through my slides as quickly as possible so that I can leave time for questions, because I do typically get a lot of questions about the Advancing American Kidney Health Initiative. And of course, if you do have questions that we don't get to, I would invite you to reach out to me by email. My email will be at the end of the presentation, and we can talk about any of these issues offline if anyone would like. So this is just an overview of what I'm going to talk about today. I'm going to give just some very brief context about the Advancing American Kidney Health Initiative, and then speak about what I see as the major provisions that have the most significant implications for dialysis practice, which are the two payment models, Kidney Care Choices and the ESRD Treatment Choices model. Then I'm going to just do one slide on updates from the ESRD PPS that was finalized in October of this year for calendar year 2020, and then just give some thoughts about what I see as coming up in 2020, and then we'll open it up for Q&A. Can I get the next slide, please? So I don't think it's going to be news to anybody on this call that in July of this year, the President signed an executive order launching the Advancing American Kidney Health Initiative. This is a cross Department of Health and Human Services initiative that sets some fairly big goals for transforming kidney care in the United States. The first of these goals is to reduce the number of Americans developing ESRD by 25% by 2030, to have 80% of new ESRD patients in 2025 receiving dialysis in the home or receiving a transplant, and to double the number of kidneys available for transplant by 2030. One question that comes up all the time is why the administration is doing this now, when so many people have been advocating for greater attention to kidney disease for such a long time, and the answer really is twofold. Some of you may know that the Secretary of the Department of Health and Human Services, Alex Azar, has a very personal connection to kidney disease. His father suffered from ESRD, initially was on in-center hemodialysis, transitioned over to PD, and then received a transplant from a living donor. So he does have firsthand knowledge of how taxing dialysis can be and the significance of the gift of a transplant. The second factor is that we are reaching a tipping point on cost. Because we have a Medicare benefit for ESRD, Medicare is paying the bulk of the cost for dialysis, and these are extraordinary expenditures of over $35 billion annually, which is a disproportionate amount of Medicare spending. So one way to think of the executive order that was signed in July is as a scope of work document for the initiative. It lays out exactly what is supposed to be done and by when it's supposed to be done. So on this slide, I've shown the sections or the key provisions of the executive order. If you click again, it will highlight the two payment. Oh, never mind. Okay, it's not going to do that. But I'm going to focus today on sections 4 and 5, which are the payment models, but I will just briefly mention the other provisions of the executive order. Section 3 directs Health and Human Services to launch a kidney disease awareness initiative. A few weeks ago, NKF did sign a memorandum of understanding with HHS and the American Society of Nephrology to work on this initiative. So this effort is well underway. Section 6 directs Health and Human Services and FDA to take steps to incentivize the development of the wearable or implantable artificial kidney. Under Section 7, HHS will be promulgating new rules on the metrics that are used to evaluate organ procurement organizations. And under Section 8, HHS will be promulgating regulations to reduce barriers to living organ donation. Next slide. So there are two payment models in the executive order, one voluntary called the Kidney Care Choices and one mandatory called the ESRD Treatment Choices model. I will get into the details here shortly, but the goals of both models, just broadly speaking, are to shift some Medicare expenditures that are currently being spent on dialysis toward the goals that are listed here. So intervening with CKD 4 and 5 patients, delaying progression as long as possible, helping patients to build confidence to manage their comorbidities and keeping them out of the hospital. For patients who do progress, paying for optimal ESRD starts, including preemptive transplants, and then ensuring that in-center hemodialysis is not the default option for patients. Paying to incentivize greater use of home dialysis and transplants, and finally paying not only to incentivize more transplants, but also keeping patients healthy post-transplant. So the goal here, and we do hope that these are compatible goals, is that this rethought treatment paradigm, which we think is the right one for patients, also happens to reduce total cost of care and represent savings to Medicare. And these models do include some incentives for providers to reduce total cost of care. Next slide. So what is Kidney Care Choices? So this is the voluntary model in the executive order, and it can be thought of as sort of the 2.0 iteration of the comprehensive ESRD care model with some modifications. Some of the bigger changes are that Kidney Care Choices does include advanced CKD patients, so patients with CKD 4 and 5. Also that patients are aligned through the nephrologist and not through the dialysis facility. Accordingly, the model does focus on payments to nephrologists and also includes some incentives for transplant. There are also numerous I think, very exciting benefit enhancements in the model that would expand patient access to the kidney disease education benefit, telehealth services, post-discharge home visits, as well as hospice. So the Kidney Care Choices model will run from 2020 through 2023 with the possibility that it is extended for 1 or 2 years at CMMI's discretion. And there are several payment mechanisms that I will cover in detail, including payments for CKD, ESRD, performance on quality and utilization measures, a kidney transplant bonus, and also the potential for shared savings or shared losses based on cost of care. Next slide. So Kidney Care Choices is one model, but it has 4 options that are shown here. The first option is Kidney Care First, which is targeted at nephrology practices only. The other 3 options, which are called the Comprehensive Kidney Care Contracting options, are targeted at other groups of providers that join together to coordinate care for CKD 4 and 5 and ESRD patients. These groups of providers are called kidney contracting entities and must include nephrologists and nephrology practices, as well as transplant providers, and can, but do not have to, include other types of providers such as dialysis organizations or care management companies. There are 3 options for the kidney contracting entities, as you see here, the graduated, professional, and global options, which vary according to how much risk the kidney contracting entity would like to accept. Dialysis organizations, as I mentioned, can be in the kidney contracting entities with the following exceptions. Only small dialysis organizations can be in the graduated option. So kidney contracting entities have 3 sources of income or losses in the model. Looking down at the last option first, in the global model, kidney contracting entities are able to receive a monthly capitated payment covering 100% of Part A and Part B expenditures. So this is known as total cost of care capitation. The second source of income in the model would be shared savings and losses. In the graduated and professional options, kidney contracting entities can be eligible for shared savings and shared losses based on a benchmark of total Part A and Part B expenditures. So in the professional option, for example, the kidney contracting entity is accountable for 50% of shared savings or shared losses. The graduated option, by comparison, would be a more moderated approach to taking on risk for shared savings or shared losses. The last of the 3 sources of income for kidney contracting entities are the payments that I'm going to get into over the next couple of slides. Next slide. So the first payment is the CKD quarterly capitated payment, which, just as it sounds, is a capitated payment that is paid to nephrologists who participate in any of the 4 options. The QCP, as it's called, consolidates the E&M codes you see here into a single payment of $242 approximately per quarter, or about $972 annually. So for nephrologists in the kidney contracting entity, this payment would actually replace the payment they receive for the E&M codes that you see here. For other E&M codes or other inpatient procedures, the normal fee-for-service payments would remain. And the purpose of this payment is to provide a predictable and flexible revenue stream that can be invested in the intensive management of patients with CKD 4 and 5 to achieve the goals of the model that we talked about earlier. So as you might imagine, whether this payment is really valuable depends on the case mix for the nephrology practice. So a practice with a patient population that needs less intensive management might actually financially benefit from this payment, whereas a practice that is already intensively managing patients with many annual level 5 visits may not benefit financially from this. Next slide. So the next payment is the adjusted monthly capitated payment for dialysis, and the aim of this payment is to eliminate payment for ESRD services that are tied to the number of visits a physician has with the payment per month, as you can see right here on the right of this slide. Instead, this payment would be set at the rate of the current capitated payment for ESRD services provided during 2 or 3 visits during the month, which is almost equal to the monthly payment for home dialysis, or it's $241 per month, or $2,914 per year. So similarly to the quarterly capitated payment, whether a nephrologist stands to benefit from this payment depends on how often they are seeing their patients on dialysis every month. Next slide. So this payment is really only relevant to the first of those 4 options that I showed, which is the option for nephrology practices only. And the only reason I wanted to include it is because while it is not immediately relevant to dialysis organizations that participate in this model, it does show what CMMI is trying to incentivize when it comes to kidney care. So this is a performance-based adjustment that is based on 2 sets of quality and utilization measures. And the quality measures that CMMI is looking to incentivize are patient activation, gains in patient activation, which measures improvements in a patient's confidence for self-management, depression remission at 12 months, and controlling high blood pressure. The utilization measures that CMMI is looking at are optimal ESRD starts, so initiating with home dialysis, a preemptive transplant, or initiating outpatient hemodialysis with an AV fistula or graft, hospitalization costs, and total per capita costs. And these measures will be included in those other model options, but exactly how that works is still a little bit up for debate. Next slide. And this is the last payment that's being applied in the model, the kidney transplant bonus, which has probably received the best press of any of these payment adjustments. This is a $15,000 bonus payment that is paid out over 3 years to providers in the model, with the largest portion of the bonus, $7,500, paid out 3 years following transplant in order to incentivize keeping patients who have received transplants healthy. And this is a very meaningful bonus that does add up quite quickly over the course of just a few years in the model. Next slide. Okay, so I'm going to now turn to the ESRD treatment choices model, the infamous ETC model. This has some very obvious implications for dialysis. I'm not going to go too in depth on the details of this model because it is in the process of being finalized through the rulemaking process, and it is subject to considerable change within the next few weeks to months. So please keep in mind that what I am going to go over here is very certain to be different. So the ETC model, as it's known, was announced on the same day the Kidney Health Initiative was launched, and it has a very clear aim to very rapidly shift the incentive that CMS views as favoring in-center dialysis as the treatment of choice for patients with kidney failure. And the model does this by randomizing about 50% of nephrologists and dialysis facilities in the country to an intervention group in which their payments for dialysis services would be tied to a combined rate of home dialysis and transplantation. The proposed unit of randomization in this model is the hospital referral region. These are regional healthcare markets. There are 306 in the United States. This model would probably go into effect at some time early next year and would run through mid-2026. And there are 2 major payment adjustments in the model: the home dialysis payment adjustment, or the HDPA, and the performance payment adjustment, or the PPA. Next slide. Okay, so this is a very complicated slide. I apologize for that. I will try to make it a little more digestible than it appears here. Starting at the top, just to review, both these payments, the HDPA and the PPA, do apply to a randomly selected group of nephrologists and dialysis facilities in the model, aiming to include about 50% of ESRD Medicare patients. So let's take the home dialysis payment adjustment first, which is a little bit more straightforward. This is simply an upfront positive adjustment to home dialysis claims. It is worth 3% of the home dialysis claims in calendar year 2020, the first year of the model, 2% in calendar year 2021, and 1% in calendar year 2022. And there are no additional payments after that. So this is intended to be a positive payment that supports nephrologists and dialysis facilities in transitioning their patients to home dialysis. There are 2 HDPAs, one for clinicians and one for facilities. The clinician HDPA is the positive adjustment to the capitated payment for home dialysis. So in 2021, for example, it's worth 3% of $242, which is about $7 per month. Whether that is meaningful or not is up for debate. The facility HDPA, is the same positive adjustment to the per treatment base rate when it's billed for home dialysis. So that is worth about $92 per month in 2021. So the performance payment adjustment, conversely, is a positive or a negative adjustment to all dialysis claims. So this would not go into effect until July 2021, and then at that time, it does increase over time throughout the model. And again, there are both clinician and facility PPAs. The scope of the adjustment is determined by a modality performance score that is based on home dialysis rate and transplant rate. Home dialysis and transplant rates are calculated over a denominator of total dialysis treatment years, and those rates are both risk and reliability adjusted. For clinicians, the PPA adjustments can range from 10% positive to 11% negative. For facilities, 10% positive to 13% negative. And certain low-volume clinicians and low-volume facilities are excluded from the PPA. And I'm going to skip attribution just for the purposes of moving quickly through the rest of these slides. Can I have the next slide? Okay, so I want to really quickly review what's new in the PPS. For those of you who are on the QIP stakeholder call this week, you may have heard CMS refer to this as an uneventful rule, which does seem to be the case. There are not a lot of new updates here. I'm not going to speak about any of them except this new add-on payment for ESRD equipment and supplies, which is called TIPNES or TIPONES, depending on who you ask. This is a transitional add-on payment for new and innovative equipment and supplies. It does not apply to capital assets, which includes dialysis machines and water purification systems. These are arguably the areas where we really need to drive innovation for patients, so this is something that the advocacy community is working on. To be eligible, the product does need to be an ESRD service. It has to be new. It needs to have a HCPCS code, and it needs to be innovative, meaning it substantially improves the diagnosis and treatment of Medicare patients. And CMS will pay for this for 2 years, after which the product would qualify for an outlier service, and no change to the base rate would be made. And I'll take my last slide. Okay, so just a few thoughts on what I see as kind of upcoming on the regulatory front as it pertains to advancing American kidney health and the prospective payment system. In 2 weeks, we're going to have a meeting of the ESRD TEP, and there are going to be some discussions of changes to the PPS, particularly as they relate to cost reporting, pediatric dialysis, home dialysis, and the low-volume payment adjuster. As we head into 2020, much is still expected from the administration on advancing American kidney health. There is forthcoming rulemaking on the metrics for organ procurement organizations and for expanding eligibility from the National Living Donor Assistance Center. Also, NKF's public awareness campaign with ASN and HHS will ramp up in 2020, so please look out for that and amplify it where you can to spread the good word about kidney health. I do personally expect that the ETC model will be finalized, albeit with some changes. And when it is finalized, there will be a bit of a scramble to figure out how it works and how it interacts with the Kidney Care Choices model. I also think it's safe to assume that we will see some legislative efforts to shape the TIPNES payment that I mentioned to get a longer period of payment adjustment and perhaps higher reimbursement during that period. And lastly, I think we are going to continue to see a sustained focus on the Kidney Health Initiative. HHS still has commitments from the executive order, but there is definitely still a groundswell of support for the work that they're doing inside HHS, and lots of champions inside HHS who have policy changes that they would like to see move forward during this time of unprecedented attention being paid to kidney patients. And one thing I think that we will see during perhaps Kidney Month in March of next year is the beginning of a conversation specifically around pediatric patients and pediatric dialysis, and part of that may be about the adequacy of the bundle to pay for pediatric dialysis. So that's it for me, and I would be happy to take any questions in the last 4 minutes. I apologize, it's probably too much on payments, but.
Miriam, that was wonderful, actually, really very clear review of what often is very complicated for us clinicians. So I really do appreciate it. We have some very nice questions so far, and I do encourage others on the line to submit questions. And if we don't have time to get to them before the hour's up, we'll respond electronically as well.
Sure.
Okay, so Miriam, the first question: goals of the executive order include increasing transplantation and home dialysis. How do you think these efforts will affect the provision and quality of in-center hemodialysis?
That's a really good question. So I think the first thing to emphasize is that dialysis is not going away. Patients will always rely on dialysis, and people will always need high-quality, high-value, person-centered dialysis. So CMS is going to continue to work on the QIP and to try to improve the QIP, to try to improve dialysis quality. That effort is ongoing. I think on the provision of how dialysis is provisioned, the goal of the initiative, and this is a goal that NKF shares, is about giving patients free choice to their treatments. And that honors that dialysis that is done in the center may be the right choice for that patient. Home dialysis might be the right choice for another patient. Being waitlisted for transplant might be the right choice for another patient. So in terms of how dialysis is provisioned, I see the biggest changes being about education and empowerment, and trying to do more to educate patients about their choices of treatment modalities. And I think specifically with the ETC model, where performance payment is going to be tied to home dialysis and transplant, that is going to be a particularly potent incentive for generating more education and empowerment for ESRD patients. On the quality side of things, when you start looking at changing the treatment paradigm, we do have to acknowledge that particularly the ETC model does represent a cut to payment for dialysis. And when that happens, we have to acknowledge that there may be consequences for dialysis organizations in how they operate. And one thing that we may see, and it's just a reality that we have to acknowledge, is that we may see consolidation and more consolidation. And whether or not that impacts quality remains to be seen. I don't think anybody can say for sure what will happen, but you know, we're talking about a cut to dialysis payments, and there may be implications from that. And the goal of NKF, and I think the goal of all the advocacy organizations in this space, is to make sure that patients are not feeling the consequences of those changes.
Yeah, Miriam, and the work that you all and other advocacy group organizations are doing is really just so important. So thank you very much. By the way, I left Miriam's email address on the screen for those who would like to contact you directly. I have two other, we're right at the top of the hour, but two additional questions maybe you could answer within 2 minutes or so, and I'll give those together to you. The first is, of course, with the emphasis on increasing kidney transplantation, is the bottleneck organ availability, and how many more organs can realistically be made available? And then the second question separately is, we have over the years and still do have a problem with referral of patients with advanced CKD to nephrologists, given we still have urgent starts in the rate of 30% or so. So do you know of any incentives that are under development to encourage referral of patients to nephrologists?
Okay, so let me take the transplant question first. I'm going to give some really back-of-the-envelope numbers here, so please do not quote me on these. But, let's say right now we're doing 20,000 kidney transplants a year. We have 100,000 patients on the wait list. That's a gap of 80,000 kidneys. Depending on who you talk to, some people believe that if we did a better job of incentivizing organ procurement for deceased donors, we could make somewhere between 10,000 and 30,000 more organs available for transplant. And CMS is heavily involved in developing learning collaboratives between transplant centers and OPOs that are very risk tolerant to try and disseminate those best practices to other transplant centers and other kinds of transplant providers to get them to use higher risk organs that are still clinically valuable to reduce kidney discards. So even if we did that, let's say we got to 30 or 40,000 more organs, that is only half of where we need to be. And HHS does know this, and if you heard them talk at Kidney Week, they said, which we agree with, that supply and demand are probably never going to meet here, which is why the development of a wearable or implantable artificial kidney is so very important, and why HHS and the American Society of Nephrology and NKF has been involved in this as well, are all working so hard to try to take down barriers to the development of that technology for patients, because I think even if we all do everything that we can to incentivize transplant and to make more organs available for transplant, we may always have a gap that we have to deal with. And on the primary care front, this is kind of a pet project for NKF on really the need for better referrals from primary care, and we are communicating with them a lot about it and trying to figure out what kind of policy levers we can pull to try to incentivize greater detection among primary care and then also referrals to nephrology. And I think it is on CMS's radar. They are hopeful. My sense from them is that they are hopeful that in these voluntary payment models that giving nephrologists a more predictable revenue stream for CKD patients will cause the nephrologist to build relationships with the primary care providers, so to have it be nephrology-driven instead of primary care-driven. And this is because there are so many more primary care physicians than there are nephrologists. And I think that CMMI is a little bit concerned that if they start incentivizing primary care physicians to do lab testing and to do all this detection, that the nephrology community will not be ready to get all of those referrals. And so they very much prefer for it to be nephrology-driven. So we are having this conversation with them about what we can do to try to improve this. There's also a great need to standardize the lab testing and to make it very straightforward for primary care physicians to do one single test and get urine albumin, creatinine, and EGFR, and to say it's really simple, it's not a big complicated process, this is just what you do, to make it really straightforward with them. But of course, primary care physicians already feel burdened with everyone saying, just do our one lab test, just do our, one thing. And so, this is a conversation that we have to keep having, but it's certainly on NKF's radar, a lot of other organizations in this space, and we are working very hard to communicate it to CMS.
Great. Yeah. Miriam, thank you so much. Yes, it's so gratifying to hear the work that you and others are tirelessly pursuing, and as you've noted, to finally have the real focus on finally turning the corner and starting to really improve care in all of these domains. So I really do appreciate this. I passed the top of the hour, and thank you folks for staying online a bit past time. We do appreciate folks calling in. We will have our next DOPPS Practice Monitor update in May of 2020 with refresh data at that time. And until then, thanks everybody. Happy holidays to all. and good evening. Thanks.